Awesome. So thank you so much. My intention here is to not be completely exhaustive, but just to start the conversation about what I think we can do in a clinical setting. And so before I begin, I want to communicate that I have no conflicts of interest, except I am a primary care doctor with a master's of public health. So I actually firmly believe that those of us who are doing clinical medicine have a role to play in actually identifying risk factors and then promoting education and research around firearm safety. So I have no financial interest, but I have a whole lot of professional interest in this important topic. And I think the place I want us to start is to really just take a step back and understand the scope of what we're talking about when we talk about firearms in America. And so it's important just to get some data, some objective data here. And there are estimates that we have about 390 million firearms in the United States. And if you understand that we're 4% of the global population, well, it actually amounts to 4% of the global population owning 40% of the firearms in the world. And that's significant. When we actually drill down and look at how many homes actually own a firearm or have a firearm present, it's 42% of US homes. So maybe another way to look at this is to say that 2% of the global population owns 40% of the firearms. So the prevalence of firearm ownership is significant. If I actually look at data from the last couple of years, the prevalence of hypertension in US adults is about 42%. So I know it's not apples to apples comparing owning a firearm to hypertension. I'm just simply trying to say that I think it's clearly an important issue for us to be thinking about just because of the rates of gun ownership. We also know that 2 million children live in a home with an unsecured firearm. That's a significant risk to them. And then 40,000 Americans die every year from firearms. That's about the same number as die annually from motor vehicle crashes. When we look at some of the age-based risk, we see that firearms are the leading cause of death for Americans between age 25 and 34, and the second leading cause for those aged 15 to 24. So I want to provide just that, some objective information, not to create shock and awe or to make us think that firearms are bad or that people don't have the right to own a firearm. It's simply just to understand the culture in which we live as we apply our population health lens. We, though, are not the only ones with information. The CDC is not the only place producing information. There is a lot of information out there. There's actually a lot of misinformation out there. And so I think it's important for us as we think about this as a public health issue to make sure that we actually try to educate ourselves as clinicians about facts and myths surrounding firearm ownership. So I have a couple of QR codes. If you feel free to scan, I'm going to show you where these came from. But UC Davis has a really great injury prevention work group, and they have some data. If you want to scan the QR code, feel free. I'm going to go on to what the QR code shows here. These are some California-based data, but interesting to point out. Like I said before, in California, there were more folks who had actually had death from motor vehicle crashes. And then actually, as cars have gotten safer, we've seen that firearms and motor vehicle deaths have become similar. Nationally, I think in 2018, we had really similar rates of death from firearms and motor vehicles. Some people think that firearm violence is a crime issue. And actually, we know that firearm suicides, which we'll hear more about later, are actually a leading cause of death from firearms. Some folks think this is just an issue with young people. And actually, when we look at the data, really elderly folks are at risk for death from a firearm, especially when we understand the risk of self-harm via suicide. And then lastly, I think in the media, we often hear about firearms and firearm-related death and injuries from things like mass shootings, or people have said we need more robust mental health services. Of course, we need more robust mental health services. But when you look at the data, the firearm injury issue isn't really one that is majorly due to mental health. Only 5% of the time is there a mental health issue in play. And only 1% of deaths from firearms are actually related to mass shootings. So this is a much bigger issue than maybe sometimes we understand if we're only just following kind of what we see in the media. And so what do we need to do? Well, I think as caring and concerned clinicians, we got to make sure we're asking our patients. So I love this quote from Gandhi: if you don't ask, you don't get it. And so we have to be willing to engage our patients in meaningful dialogue to ask questions. So we talk about car seats, we talk about bike helmets. I tell mothers to not feed their child under 12 months of age that they shouldn't eat honey. I should certainly be able then to talk about firearms because firearms are a whole lot more dangerous to a kid than honey. And it's especially important to be screening about firearm ownership and safety in certain populations. That's not only houses with children and adolescents, there's also folks who have mental health issues that might increase their risk for suicide, folks who are experiencing interpersonal violence. That's important. And then also patients with dementia. It's not uncommon to have that patient who hunted all their life and now they're 70 or 80 and they just shouldn't have a gun in the home anymore. So just got to make sure that we're checking in with those folks. And so I want to give a quick clinical vignette to demonstrate kind of where I think this shows up for most of us. I think it shows up for all of us actually every day in the clinical setting. So this is a real story from actually like a month ago. JC is a 45-year-old who identifies as Caucasian, cisgender male. He presents for his annual preventive health exam, which was postponed due to COVID. In addition to routine wellness recommendations, i.e., should I get my cholesterol checked? What's my blood pressure? He wants to discuss increasing stress related to raising his 15-year-old son with his ex-wife. So this is like bread and butter family medicine. I will see this multiple times, this week, as will you. The question is, do you see, can you read between the lines? Can you recognize that this is a spot where we should be and can be screening for firearm ownership as well as injury prevention? So let me just talk about how I would approach this patient and some of the tools that I use. It's really important that as we're moving towards this, we really invite discussion with our patients about firearms. So I actually have some really welcoming language I try to use. So I'll often have some phrasing like, a lot of my patients own firearms for hunting or personal protection. I want to check in to see if you own any firearms. And so it's really kind of an invitation for discussion. And I actually use the term firearm instead of gun because I think it kind of softens things a bit. When I feel like someone is really going to maybe take exception to be asked about their guns, I may step way back and be like, hey, living in Wisconsin is awesome. A lot of us like to go hunting. Do you go hunting? Oh, do you own any guns? And I just try to find a way to naturally build into the conversation a question about firearms. I'm typically doing this during my social history screening. So I've already asked about tobacco, alcohol, recreational drugs, and sexual activity and STI risks. And then for me, I found that actually asking about firearms at that time feels actually like a relatively appropriate thing because we've already talked about some really important things, and patients tend to be pretty forthcoming about answering questions. And when I'm asking these questions, I'm not just like, do you have a gun? I want to know more about what they own. So I want to know, like, tell me more about the firearms you own. What do you use them for? Because a hunting rifle versus something for home safety or self-protection is different. I want to know what kind of firearms folks own, how often they use their firearms. And then my key question is, what's your plan to keep your firearms safe? And actually, that's exactly the conversation I had with JC. So I said, I didn't know he owned any guns. I said, do you own any firearms? And if so, what's the plan? And he was like, oh, yeah. Now that I think of it, I got a couple of hunting rifles down in my basement up in the rafters, but they're not locked. I don't keep my ammunition there. I keep it separate, but that's not locked up. And then he answered his own question of like, oh man, I should probably do something about that. And so the chance just to bring to awareness for the patient that there is potentially something dangerous in the home really actually can help lead to action here. And as I'm unpacking this and talking through kind of counseling on injury prevention with firearms, I really want to do some screening and just identifying, what we need to put into place to make sure that we're keeping those firearms safe and secured. So I want to screen for things like, are you at risk for self-harm? And if there's a concern about suicide or self-injury from a firearm, I'll talk to the patient about a temporary firearm transfer. So giving a gun to a trusted friend or possibly to a gun shop so they can be held for a period of time until the person feels like it's safe to bring the firearm back into their home. I'll also ask about at-risk individuals in the home, such as children. It's important to recognize that this isn't just asking like parents who have young kids in the house. It's also asking grandparents, do you ever have your grandkids come over? So literally, as I was creating this PowerPoint, the afternoon after I created the PowerPoint, I saw a 78-year-old male for his annual wellness visit. I asked, do you have any guns in the home? He said, yeah, I have a loaded pistol I keep on a high shelf. And I said to him, do you have any grandkids? He said, yeah. I said, do they come over? He's like, twice a week. I said, you think they could reach that top shelf? And he said, I should probably lock up that gun. And so the key is if I hadn't asked, I never would have known. And that's just important to make sure that we, again, are bringing it to the level of awareness for our patients and talking about this. I think it's also important if patients don't own firearms, that we're encouraging them before kids go for a play date to sometimes check in about that. So it should be comfortable to ask before a play date, hey, my kid's coming to your house. Do you guys own any firearms? Just to make sure that you're aware of that. And then counseling kids, parents should be counseling kids if they see a gun, we assume it's loaded and we don't touch it. One thing that's important that I'll often point out to parents of my pediatric patients is children who live in a home with a firearm are 3 times more likely to die from suicide. It's not because a gun in your house makes you more depressed or more likely to have suicidal thinking. It's that access to a firearm is much more lethal as far as suicide completion. That point alone right there often helps parents start thinking about, yeah, I got to do something to make sure the guns are kept safe. And so when we get to that point, we start talking about principles of safe storage. And it's important as we're talking to patients about this, that we're really talking about every single firearm you own. And so every one should be locked. That could be a trigger lock or a cable lock that goes through the chamber so you can't actually fire the gun, or it could be a safe. The gun should be stored unloaded. Ammunition should be separate, and the ammunition ideally would also be locked. And then really important to make sure that however things are being stored and secured, that they're inaccessible to children or high-risk individuals. So it shouldn't be like, oh, it's locked in a safe, but then the key is left out in the open. It shouldn't be that anyone could just easily guess what the combination is for the safe, things like that. So you might wonder, like, okay, I've done all that. How do I tell my patient where to get these things? So there are tons of outdoor shops that actually have everything that a person needs to keep their gun safe and secure. So things like trigger locks, cable locks, gun safes, all of those can be purchased at any of the places listed here. I have no vested interest in if you go to Gander Mountain or Walmart. Actually, Amazon is pretty slick because people can hop on there and have things, including a gun safe, shipped to them, within a couple of days. Some people aren't comfortable, walking to Walmart or Gander Mountain, but they might want to go to their local gun shop. So I'm fine saying, hey, where do you buy your ammo? Why don't you go there and ask them about how to keep your gun secure? And folks are pretty open to that, going to a place that they know and are familiar with. The last thing I was going to say is, I think it's important for us as clinicians to make sure that we are getting adequate training so that we are able to help our patients. When folks who own firearms are queried to ask who they think is the most trustworthy resource about firearms, physicians universally score very low. So folks who own guns don't think their doctor is going to be in the know about guns or be helpful as far as giving counseling. So I think one thing we can do is consider just a little bit of additional training to make ourselves more familiar with what we're talking about, because we do have a role to play as far as helping patients prevent injury. One resource I love, which is a bit time consuming, is a 6-week online course from Johns Hopkins called Reducing Gun Violence in America, Evidence for Change. There's a QR code right there. It's free of charge. And it's all these small little snippets of videos. Really well done. You can go at your own pace. So you can go more than 6 weeks if you want to. But a really nice primer on firearm 101, as well as policy and what you can do clinically. The Bullet Points Project is really awesome. That also is through University of California, Davis. Has really nice clinical tools, including things you can print and put up in your office about safe storage of firearms, as well as some clinical vignettes and clinical encounters that you can actually go through to kind of practice a little bit of the dialogue that you might want to use with patients. And then lastly, Affirm is a great research organization that has some really nice physician-based and kind of clinical-based information that you may want to, if you want to dig in a little bit deeper, you can check out that website as well. This is not an exhaustive list. There are many other things you can do, but I think these three options are some nice things to start with as you're thinking about kind of further next steps. Those are my references. I know we have two more excellent speakers, so I'm going to just press pause right there, and then we can transition.
Thank you. Thanks, James. And now Anthony. I'm also going to share his screen here.
Yeah, that was phenomenal, James. I want to say thank you for sharing all your knowledge with us today. Let me share my screen. So just to be able to talk a little bit more about our organization, we are focusing on interruption. A bit of my talk is really coming from the community aspect of the way how, not only the way how we work in the community, but also how we have to be able to work in the community together. That's also being able to, that's including physicians, that's including nurses and so on, and also including law enforcement, and saying, you know, it's the approach, the more that we work together as a community, that's the only true way of us really being able to ending gun violence. Excuse me. So again, these are just some of the instances that what we talk about, not only when we are responding to the hospital, when I'm sorry about that. When we are responding to the hospital, but then also as we're working to partner with different community agencies, as well as being able to as we navigate different situations when a shooting occurs. That means as far as talking with physicians, it means as talking with nursing, the nursing team, as well as social workers. Everyone is a critical partner in the way how we navigate, but then also how we also come together to being able to help the family members in their time of need. One of the biggest impacts that when we talk about trauma, we talk about the way how we talk about generational trauma and the things that are going on out in the community, but then also some of the things that can actually happen right in the mix at the hospital as well. And for many of you, I'm assuming, so hopefully, the knowledge that what I'm just showing, that my PowerPoint is basically just kind of spelling out, this is stuff that we know is already happening, not only just in our community, but this is, you know, throughout the United States. That where it kind of gives us, you know, as we're talking about, you know, even though, say, Black and brown people in the community may make up a small portion of that community, but are most impacted by violence. And then also, you know, but then also, and we also get a chance to be even talk about what is actually being reported as well. So, you know, we go from shots being fired before someone is actually being hit that may happen in a community, then into the next following day or week or even month at times that actually someone has been impacted by violence directly, meaning that they have been shot. So I just want to just kind of, this is just one of the stories of some of the, of our outreach workers and the way how we work with people. We have to be able to make sure that we're working with people all throughout. That means all throughout the process, all throughout from the fact that when they're at the hospital to also, because everyone who once they leave the hospital at some point, they're either going back to their community, relocating to a different community, or or actually going back out to maybe even committing a crime. And so our whole, through our organization, we're making sure that we're connecting with them on all points. One, being able to make sure that there's an easy transition and they're being open and honest at the hospital, but then also being able to work with them in the community as well, to being able to help them navigate and to be able to get their life back on track. And of course, it's different for everyone. So here, this is just one of our community safety workers working with a young man out in the community. Again, this is because we work on both sides. We work with the excuse me, we work with the perpetrator as also with the individual that who also and also the victim. I'm sorry, a little bit of dry throat there. Also, we're working with the victim as well, and being able to provide a different type of balance and being able to connect them with different resources throughout the community. And it looks different, and it looks different for everyone. It looks different for by the way how we are most impacted throughout the community. Actually, our outreach is something that because we do in-reach as well as outreach. That means in-reach inside of the hospital. If someone is at the hospital for extended time, we're also working with them there. But then also even afterwards, making sure that we're connecting them with other services throughout the community. Again, this is our community safety workers working with others because and again, I do want to make sure I mention this, through our strong partners through UW Health, but then also being able to navigate the system with Madison Police, and also, having those real hard conversations, but then also stepping in when we can to be able to intervene when they know, because the law enforcement knows a lot of times when there's certain things that, whether if it's from wiretaps or whatnot, we're able to still have some additional dialogue. So if they hear it may be a possible shooting or something, it gives us the opportunity to be able to at least step in. And of course, it's all voluntary. It's one of those things that, not saying that we can stop or fix everything, but we can at least be able to allow people to know, hey, look, you have a choice. And when people hear that, it at least be able to give them something to be able to either change their mind or know that, hey, a lot of times you have that one person that when either myself or some of our other outreach workers, we're on their shoulder, allowing them to know, hey, that whisper, man, this is not the choice that you want. Think about all the people that you will be impacting, not only your family, the other person's family, but then also, what is it that you really want out of life? And those things work. And a big part of that, again, it is really kind of helping and reimagining what public safety looks like as well. This is just a few of our partners in the community, from Days, Rainbow Project, Public Health, UW, obviously, and Nehemiah, City of Madison Police, Dane County Madison Police. Is important that we have all these different partnerships, even collaborations also with the Boys and Girls Club, because these young men, these young girls, they eventually they will become adults. And at that point, being able to talk about what it is that they want out of life and being able to change their mind, because everyone is coming from a different situation in their household, regardless if they're at school, regardless if they're out in the community, which is being able to really give them a different, not only foundation, but then also being able to let them know there are other folks who can be trusted in the community. Again, this is just a path to ending gun violence, increasing our individualized outreach program. That's what we plan on doing, expanding community safety workers pilots, adding to our new CSW program, and also being able to add on to our outreach program as well, increase collaboration and awareness around solutions throughout the state of Wisconsin. This is our lovely team. I say lovely. I say my team tells me a lot that I say lovely quite a bit, but this is our lovely team that, again, to be able to get the work done, it takes a village. The village, it has to look differently, and we have to be able to mimic what that village looks like. And here is our website. And then also on our Facebook as well. And we're working on Instagram here currently. Thank you so much for allowing me to speak here. I'm trying to stop sharing my screen. And I just wanted to say, really appreciate the opportunity of just being here. I want to make sure that I want to pass, I guess, and a lot of times we say pass the mic over to, to Jen, as she is phenomenal. Thank you.
I'm Jean Papalla. My pronouns are she, her, hers. Thank you for having me over your lunch hour. Thank you for giving me this time. I work about 5 hours a week for Safe Communities of Madison-Dane County. I also have a rather interesting part-time job for the Department of Health Services, where I work on the violent death reporting system. So my job is to read in the state of Wisconsin all the homicides, suicides, undetermined deaths, and law enforcement interventions. So I am the fly on the wall reading the police report, the coroner's report, the toxicology, the autopsy. So I get a much broader picture of not just how it happened, but kind of the whys and the multifaceted parts that come together. I'll let you go to the next slide. In 2009, in the course of less than a week, 3 people who had no connection to each other all bought a firearm at the same gun shop in New Hampshire, and they all killed themselves within hours of the purchase. The state medical examiner brought that to the attention of their mental health liaison and a small group of firearm retailers, and they got together and met to explore whether there was a role for gun shops in the prevention of suicide. It sounds like something we would say, but of course there is. But in 2009, gun shops and suicide prevention people were not in the same room. The Gun Shop Project in New Hampshire has been replicated in 21 states. The original Gun Shop Project looked at solving the problem of impulsive suicides. Impulsive suicides are those which the purchase of the most lethal means, which is almost always a firearm, when the firearm is used within hours or a day of its purchase. We know that it accounts for about 10% of all firearm suicides. So the Gun Shop Project had great promise because in the gun shops, the gun shop and retailers helped put together literature that guided people who were thinking of buying a firearm to help or assistance or to community resources. The part that was missing was, what does this mean for the other people who already have a firearm in their home? So in 2015, the Gun Shop Project came to Dane County through Safe Communities. And one of the first people I spoke with is the gentleman you see on the right, Chuck Lovelace. And he's the owner of Essential Shooting Supplies, which were in Mount Horeb. Chuck was completely embracing of the Gun Shop Project. I think he was one of the first to frankly admit that as a gun shop owner, he knew he had sold a firearm that was used in a suicide. It had come back. The investigation with the sheriff had led him to know, and he felt just awful and felt that there was a role. And he liked the idea of the Gun Shop Project, but he said, I think you're missing something. He said, how come you're not including gun shops as a place that could safely store firearms? So we were handing out materials that talked about safe storage, and we developed them with Chuck. We looked at other states that had done similar types of information. So we would now have posters, for example, in gun shops that say things like, gun owners, you can help put time and distance between a suicidal person and a gun, and that can keep them safe. So we were starting to present the option that gun shops were not the problem. They were actually the solution. Let's move to the next slide, please. Can you move to the next slide, or do I do that? Thank you. So one of the most important pieces of paper, and boy, for a small piece of paper, it took a great deal of time, was a card that looks very much like a MedDrop card, and it says what to do with guns when a person may be in a crisis. And this card, which we worked on carefully and in careful consideration with Chuck, who became kind of our expert in the field, is meant to help people have the conversation about what to do. So it used to be if you had medication in your house, people thought, oh, you should, throw it in the trash, flush it down the toilet, all the wrong things. And now we have MedDrop cards, which says, oh, you probably didn't know, but this is how you can make your home safer by disposing of your medications. This card is meant to be the same thing, but the situation is how to safely store your firearms. So let's move to the next slide. The idea was to make it a very sequential step by step. We said, if you have firearms in your home and you think someone may be going through a crisis, and I use the biggest word I can because crisis covers everything. It's not just suicide. It can be people going through divorce and financial problems. It can be interpersonal problems. So anytime you're in a crisis, you may be at a higher risk if you have an unsecure firearm in your home. So we said step number one would be to turn it over to a trusted family member or friend. This is the least stigmatizing way to safely store your firearm. It does not involve everybody being in your business. You just take it, you take your firearms and you give them to a friend. And I know from reading the suicide reports that people have done this. There have been circumstances where family members have recognized someone in a crisis and they have moved the firearms out of the home. Of course, I am reading suicide deaths, so clearly the firearms have gone back into the home. It isn't perfect, but there's knowledge that an unsecure firearm in the home could be a problem. And then we have the second aspect, which is contacting your local gun shop. We also recommend you can rent a storage facility. We make suggestions about how to lock it up and how to get cable locks. I should mention that Safe Communities is able to provide free gun locks. If you want to have them at your clinic, you could just hand them out right there if you wanted. On the left side of the screen are 2 local gun shops, which will provide low-cost, safe, temporary storage of a firearm. And I am working with a project, which I'll tell you about a little later, with the Veterans Affairs, where we hope to have gun shops all over the state of Wisconsin, which will provide safe temporary storage of firearms. Go to the next slide. It's clear by literature and review, the best is at meansmatters.org, which comes out of the Harvard School of Public Health, the T.H. Chen School of Public Health, that if a person in crisis can be kept away from a gun temporarily, we can prevent suicide. That we don't need to do a lot more research on this. It's already been well studied. But only recently have we viewed the firearms community and gun shops as partners. I mean, to be frank, we used to treat them like drug dealers, that somehow they were part of the problem. And part of this partnership working with safe storage has been the connection between gun shops and suicide prevention advocates. So it can be what seems like a difficult conversation, except it isn't, because there's the perfect meeting point of safety and respect for the culture. Let me give you an analogy. I enjoy quilting. I make quilts and I've collected quilts. Mennonite and Amish and Quakers are all in my family history. Don't let my last name fool you. And so I have quite a few quilts, and I also like to make them. So people who sew and collect quilts often will collect material, lots of material, and they just kind of will see something and just go buy it because they think later on they could use it. And we like to store it in boxes, and we like to have it available. And we enjoy sometimes sharing, our materials and our quilts and our patterns with other people who enjoy quilting as well. So I would become quite annoyed if someone sat down and started questioning me about why I was collecting so much material and why was it that I had, 3 bins that all had calico in it. Isn't that a little excessive? Maybe just, 1 bin? Why do you need to have all that there? And why do you need all that one colored cut and strip fabric? And I'd say, well, that's for the edging, of course. And then I need to have boxes of batting. You kind of got a lot of that there. What are you going to use it for? I'm not seeing you sewing right now. And I would be like, but I enjoy quilting. So use that conversation when you can imagine you're having a conversation with someone who has firearms, which are indeed legal. Firearms can be passed down father to son. There's an important cultural connection. Many people have firearms in the home for hunting. And I'll tell you the memories that particularly father-sons enjoy of hunting together, spending time together in the woods is very important. And that firearms, it becomes kind of a memento of the time spent together. So we also know that gun shops are important places where people gather, much like I might hang out at a fabric store. It isn't just to make a purchase, it's to talk to the people in the store and find out more. And that's how it is with gun shops. In one article, a woman said, the firearm community has a very strong bond. People don't go in just to shop. They go in to hang out with the owners and the managers, and there is a lot of trust there. So the biggest part of safe storage was, why don't we use the trust people already have in the gun shops and the willing gun shop owners to help prevent suicide through safe storage? So let me play this quick 1-minute video. This is Chuck Lovelace, gun shop owner and a decorated Iraqi war veteran.
Firearms are used in suicides quite often, and what we want to do as retailers is kind of identify some of the suicidal tendencies that people may have, where they don't really care what they buy, they don't really care how it works, and just trying to identify those risk factors and train our staff to understand what those risk factors are. So what we wanted to do was, start to limit access for people who may be in a crisis. We started the safe storage program, and what we did is we went out and we secured a safe and got it all set up for people to bring their firearms in and have them stored while they're in a crisis. We contact them after 90 days, and then we contact them after 180 days, just to make sure that they're on that road to recovery and at that place they need to be. And if after 180 days they're not ready, then we start looking for other options for them. But we're not mental health professionals. We're not here to help diagnose and treat the problem. We're here to help limit access to a potential tool for suicide. What we're trying to stress to people is this isn't about gun control. It's about limiting access in a time of crisis.
This moment brought to you by WCA Group Health Trust.
Thank you. And you can bring up the final slide. So we took the idea of the gun shop project, and as working on, I also am working on the governor's challenge to prevent suicide among service members, veterans, and their family. And in the governor's challenge, we are looking at safe temporary storage of firearms. We know that 1 in 5 suicides involve Wisconsin veterans. We know that Wisconsin veterans are more likely to report physical health problems to their physician and less likely to report mental health problems. While firearm deaths for suicide are at about 49 to 50%, we know that firearm suicide deaths are higher among veterans, almost 70%. But we know that suicide is higher among males and those who own firearms, which focuses on the veterans group. So I'll take the next slide, please. So what we've been working on is a combination of the gun shop project and the safe storage program. If you go to BeThereWisconsin.com, we have created two parts of a program that we're trying to expand statewide. One is having gun shops be available to put out information on preventing suicide. You should be able to see a poster. You should be able to get a card about the hotline you can call. We also have materials that we are sharing, as Chuck mentioned, with the gun shops so that they can stop guns at the point of sale. Gun store owners, they totally understand when people come into the store and they seem hesitant about purchasing a firearm. The gun shop owners will make a point of inquiring more and making sure that the firearm they sell them is the most appropriate, that the person knows what they're doing. They have great respect for the firearms as well. And then the second part of the Be There Wisconsin is an interactive map, so you can go and find safe storage. So as I said, you can make that recommendation in Dane County by just Safe Communities has created the Palm card, and you can have that Palm card available. So I'll have the next slide, please. Means restriction counseling. Learn about means restrictions counseling. So what that is your ability to talk comfortably about safe storage. So I say that you should be talking about means restriction counseling to everyone. You don't have to, in your mind, decide if it's only going to be this person or that person or that person. We talk about at Safe Communities creating a safe home. And a safe home is one where no one is going to overdose on drugs, have access to a firearm that they shouldn't, and or slip and fall or trip on a rug, anything that can create a safe home. And I think it's a natural conversation. Please don't think that the conversation about suicide should only be with people who have a diagnosed mental health. We know that that is involved in half of the suicides, but we know the other half have no mental health. Red flags, so to say, that would lead anyone to believe that they were thinking about suicide. In the reports I read, one of the most common things that I read when the family is talking to the coroner or the medical examiner is that the family was completely blindsided by the suicide. They never saw it coming. They did not see the risk factors, and they didn't know that this was even on the radar. So I think having the conversation about creating a safe home is for everyone. You don't need to know anything about firearms. Which I don't know, maybe you find that good. If you know something about firearms, that's great, but you don't need to know anything about a firearm to pick up one of the cards that we will have. And much like Dr. Bigham said, is at the end of the conversation to be able to say, hey, unsecure firearms can be a problem in the home. Here's a card. And you know, there's something about being a little vulnerable yourself. Perhaps you'll say, I don't maybe know everything about firearms. You know, if you don't know the difference between a rifle and a shotgun, if you don't know between a semi-automatic and a fully automatic, it's okay. You don't have to. And to say, I don't know is fine. Say, but here's what I do know. I want to make sure that your firearms are secure. If you have any questions, these are the experts, and you can point to the gun shop and you can flip over the card, which has the 3-step process. But I don't think you have to ask them about how many guns they have. You don't have to ask them what kind of guns or what they're going to use the guns for. That can be kind of off-putting to gun shop people who own firearms. I think what we want to talk to them about is safety, and you are in the expert position to be able to do that. And I will turn it back over. This is additional information. I did want to read you one thing from this excellent article from the American Psychological Association. And the author says that clinicians tend to have inaccurate perceptions about the effectiveness of means restriction counseling. which means talking about it. So in a study, for example, clinicians estimated that less than half of their gun-owning patients would take active steps to store their firearms locked away and unloaded if recommended by the clinician. And the actual number who did was 63%, which I think speaks to what Dr. Bigham was saying about how, that moment of like, I think I should do something about it. Bringing it up started the conversation. And we know that the barriers to more widespread and routine implementation of means restriction counseling are due primarily to a lack of clinician education and training. And this article urges that. For example, they said 80% of the emergency room nurses had encountered a suicidal adolescent in the course of their routine practice during the previous 6 months, but only 28% had provided means restriction counseling to the parents. So, until you know about it, it's difficult to spread the word. So anything you can do so that you feel comfortable. And I want you to know that feeling comfortable doesn't mean being a firearms expert.
Great. Well, thank you. Thank you very much to all the panelists. So we'll have time here for questions. Again, if you want to put those into the chat. And for that, I have a couple of questions. So starting, James, I really just love that. What is your plan to keep them safe, in terms of really honing in on, the themes also that Jean just outlined about focusing on safety. The question is, I think there, as clinicians, there at one point was considering there might be pushback on talking to patients about firearms and looking at the law in Florida that was fortunately overturned, but I just wanted to see what your experience, since you've started to screen people, what your experience has been asking people.
Yeah, my experience has actually been universally really well received. So I actually screen everybody when I'm doing their social history. And so people actually say, hey, I don't own firearms, but thank you so much for asking. I appreciate that you're asking people. I appreciate that you're helping to make sure that we're having a safer community. And I would agree with Jean, I don't think you need to know what the individual owns necessarily or how many guns, because that can come across kind of inappropriately or like, we're trying to get guns. I, I'm the kind of person though with my patients where I'm building relationships. I'm trying to lean in and help them just think critically. And so I often actually ask in kind of like a aw shucks way, like, do you have a right, do you use it for hunting? Is it for self-protection? And then I help them think about how they might keep it safe. So a hunting rifle, you use 2 weeks a year, you could literally disassemble and like lock up and like put it in your storage unit outside your home. A, a handgun you want to use at 2 a.m. when someone breaks in, you might have actually like chamber empty, but like magazine clip ready to go into it in a safe next to your bed. And so I just try to help understand the process for the patient, talking through if they know nothing about how to keep their gun safe, like here's some options. You don't have to know that much about firearms to screen. I would agree with Jean. It's just simply asking and providing resources. I've had one patient who just held on to the side of his chair and he's like, "You're coming for my guns." And I was like, "No, man, trust me. I'm not coming for your guns. I have a 3 and a 6-year-old at home. I'm just trying to make it through my day and go see the Brewers tonight. So like, I just want to keep you safe." I really lean into the injury prevention side of things. And I say, just like I'm talking to you about your blood pressure, just like I talked to you about wearing your seatbelt, I want to talk about firearms. And I really actually frame this a lot with the seatbelt discussion. This has become politicized. It's not a political issue. Seatbelts were politicized in the 1980s. If you look back at the data, when we put seatbelt laws in place, we saw a precipitous decline in motor vehicle injury deaths. And so helping people understand, like, no one ever thinks about when your doctor talks about locking or, clicking your seatbelt, we should think similarly about firearms, and we just need to move the cultural view on this, and the dialogue we have with our patients is a really important key for that.
Great, thanks. Anthony, question for you as you are looking at growing the organization. In terms of how we could connect in outpatient medicine, I know a lot of the referrals are probably most are coming from the hospital base, but how do you envision a connection with the outpatient clinics?
So, I mean, primarily it would be a call or an email. Typically, I'm able to have one of my team members either come directly to the hospital, or we set up an appointment. It really all depends on what the situation is for that individual. A lot of times we've actually been called to, well, I shouldn't say a lot of times, but we've actually been called to some of the clinics just to, if anything, just to be able to do a hard handoff. In our world, that's what we call it. We call it hard handoff, to making sure that, hey, so if I'll say Dr. Bob, right? So Dr. Bob calls and say, hey, I have a young man here that may have some additional challenges. Do you have someone that can probably stop up, and he's willing to meet someone now? So then that way, if it's possible, then I can be able to send one of my team members there to meet with him at that very moment. But then afterwards, or sometimes, even if it's not, we make sure that we are at least being able to get on the phone with that gentleman or young lady. And then make sure that we have a meeting with them, whether if it's coming to their home, setting up a Zoom, setting up a time that where they may even, when the doctor may know for sure this person always comes back at least to their doctor's appointment. Or excuse me, being a part of that meeting as well. People, being able to really step out the box. And so there's different ways on how we connect, but it's the whole thing of making sure that we're also connecting with them outside in the community as much as possible. Because the focus is, especially if they've had some incidents with violence, even to them, or they may even be thinking about perpetrating violence to the community.
Great. And Gina, I wanted to ask you, it's such an extraordinary program between with the gun, both ownership and then the storage with the gun shop project. And when we look at the ERPA laws, extreme risk protection orders, I just wanted to get your feeling on, there are so many different types of ERPA laws, if we look at the different states, and then also some, pushback regarding libertarian views of those protection orders to take the guns. So I see this as a really nice way of, it's voluntary. But I just wanted to get your opinion on ERPA laws and in terms of suicide prevention.
Indeed, ERPOs have been introduced in many states, and they have great variety on a state-to-state basis. I'm trying to work with some legislators now on it, and the only thing that has gotten me not tossed out of their offices is the fact that I'm willing to say, how about we think about something that is a distinctly Wisconsin version? So I think the beauty of ERPOs and why it works better at a state level than a federal level is how we do the procedures and who's taking part in it should change state by state. So for those of you not familiar with extreme risk protection orders, it is basically similar to a restraining order. It's a civil suit where petitioners, it can be the police, it can be family, it can be physicians, it depends what the state picks, is able to petition to have the firearms removed from someone's home based on dangerousness, and the judge makes the decision based on previous incidents. So as a Chapter 51, for example, would be to commit someone civilly for treatment based on the dangerousness of a mental health or a substance abuse disability. An extreme risk protection order would not require a mental health problem. It would be to show dangerousness. You can see where it's fraught with some points that would become very concerning to legal gun owners who feel that someone could, the wife gets mad at me and then she decides she's going to stick it to me and she goes to court and she makes up this order and all my guns disappear for a year. That's the most common scenario that we've heard. You know, it wouldn't happen that way because there's a judge in between who's looking out, and that's the due process part of it. So the safe temporary storage of firearms through safe storage, meaning you voluntarily bring them over to a gun shop, is completely separate from an extreme risk protection order, and it is, as you said, more voluntary. We believe that it would be easier for gun owners to have their guns safely at a gun shop that they trust rather than taken away by what they view as, you know, a repressive system of government.
Yeah, exactly. So, well, we are up against the time here, so I just want to thank you all for participating. I think our role, you know, extends definitely beyond the office into the community, into policy as we look at this, addressing this public health issue, gun injury prevention. So, thank you, and hope everyone has a good rest of your day.